pain if their knee is completely straight. Okay? Michael's kneecaps are quite lateral.
I guess so.
All right. So how I would normally start palpating the knee is I would be facing the patient. This way I can talk to them. I'm going to put my thumbs on either side of the infrapatellar tendon. Okay, so I'm here. That gives me my landmark. I will follow the infrapatellar tendon down until I'm on the tibial tuberosity. Okay, so does anyone have Osgood ladders in here?
Is that a bump?
Yeah.
Yeah, I do.
Okay. So you can palpate. Except no one wants to touch you because Maddie gave you a workout.
Yeah.
So I'm on the tibial tuberosity. I can come up and I can palpate the infrapatellar tendon. Okay. I can come up and palpate the patella itself. When I'm looking at the patella, I'm looking at its orientation relative to the femur. So I'm looking if it's tilted this way or this way. Normally, we won't do it in this class, but you would actually do some glides on the patella to see how it's moving. I would then go back to where I was, and my fingers are relatively flat, and that's the other thing that has so impressed me with your videos, is everyone is using really, really nice palpation techniques and palpation hands. You aren't doing this. You're doing a great job of really putting your whole hands on. To find the joint line, do that again and just put your fingers flat on, and you will feel that space between the tibia and then the femoral condyles. So then I would come across the medial collateral ligament is going to run this way. The MCL is much less distinct than the LCL. So I'm going to palpate across here. We're not going to be able to palpate the meniscus. You're looking for reproduction of symptoms along that joint line, which might be indicative of a meniscus. On the lateral joint line, I found that earlier when I just put my hands on there. The LCL, so the lateral collateral ligament, is much bigger. So if you cross your legs, you'll make your LCL pop out and you'll feel that it's a pretty big cord crossing your joint line. So if you can't find it on your patient, you could also cross their legs and feel that there as well. Now on your list, you have the medial and lateral epicondyles, so you can palpate those. If you go posterior to the condyles, you're going to find the supracondylar ridge, okay, similar to what we found on the humerus. On the medial side, if you follow that medial epicondyle up, you're going to hit the adductor tubercle, where the adductors are attaching. Okay. The pes anserine attachment is going to be on that medial border, just inferior to the tibial plateau. There is a pes anserine bursa, which is going to be underneath the attachment of your pes anserine muscles. So I don't know if that's, I think it's Latin for duck foot. I actually, last month, I was so excited I thought I'd be able to show you guys because I actually had pes. Moving the foot up will cause the fibula to go up and down a little bit, so you'll know that you're on the fibular head, and you can go ahead and relax. The common fibular nerve, otherwise known as the common peroneal nerve to those of us who are a little older, is going to wrap around right inferior to the fibular head. So follow that fibula distally a bit and then go posteriorly and come forward, and that nerve will be right there. Okay? The nerve is crossing across the fibula pretty transversely right there. And so you're going to want to go cross the nerve, and so you're going to go up and down. Okay, so I'm on the posterior aspect of his fibula, and I'm going to go up and down there. Okay. All right. Did I miss